ദൈവമേ, ഞങ്ങളങ്ങേ സ്തുതിക്കുന്നു, വാഴ്ത്തുന്നു, വന്ദിക്കുന്നു, മഹത്വപ്പെടുത്തുന്നു. ഒരു വ്യാഴാഴ്ച ദിവസം കൂടെ അങ്ങ് ഞങ്ങൾക്ക് ദാനമായി തന്നല്ലോ. പുതിയ കാര്യങ്ങൾ കേൾക്കുവാൻ, പുതിയ കാര്യങ്ങൾ ഗ്രഹിപ്പാൻ, അത് ഞങ്ങളുടെ ജീവിതത്തിൽ, ഞങ്ങളുടെ പ്രൊഫഷണൽ ലൈഫിൽ ഇംപ്ലിമെൻ്റ് ചെയ്യുവാൻ കിട്ടുന്ന വിലയേറിയ സമയത്തിനായി നന്ദി. ഇന്ന് അത് അവതരിപ്പിക്കുന്നതായിട്ടുള്ള ഡോക്ടർ ജോൺ വില്യറ്റിനെ അവിടുത്തെ കരങ്ങളിലേക്ക് തരുന്നു. പരിശുദ്ധാത്മാവിൻ്റെ സാന്നിധ്യം, നടത്തിപ്പും അദ്ദേഹത്തിനോട് കൂടെ ഉണ്ടായിരിക്കണമേ. ഞങ്ങൾ കേൾക്കുന്ന കാര്യങ്ങൾ ഞങ്ങളുടെ ഹോസ്പിറ്റലിലും വരുന്ന തലമുറയ്ക്കുമൊക്കെ അതൊരനുഗ്രഹമായി തീരുവാൻ സഹായിക്കണമേ. വന്നു ചേർന്ന് ഓരോരുത്തരെയും അനുഗ്രഹിച്ചാട്ട് ഞങ്ങളുടെ കർത്താവും ഞങ്ങളുടെ രക്ഷിതാവുമായ യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Good morning and welcome to another interesting session of Quest. Today's session will be taken by Dr. John Willett sir, our Associate Director. It's always a curiosity on what sir has to present, even though the picture and the title gives us some clue. Inviting sir for the presentation. Thank you.
Hello. Good morning, everybody. Emergencies don't give notice. I said emergencies don't give notice. They erupt like a volcano, spontaneous, without warning. And it calls for spontaneous, coordinated action. And it calls for instantaneous team recruiting. Today, I want to talk about the extraordinary power of instantaneous team recruiting and motivating the team and achieving the endpoints. I may present a few cases, but not for the clinical interest, but to illustrate how instantaneous, spontaneous team action either led to success or failure. This is an AI-generated picture of an actual happening which occurred about 25 years ago. I owe this picture to my friend Dr. Riju Matthew. He's an expert in AI. I was in Muscat and I had a meeting which I had to reach around 5:30, and I was trying to get out of the doctor's residence area where there were two barriers, one to go in and one to come out. And it was visiting time in the hospital, and there were lots of cars, and someone had parked a car right at the exit, and cars were backing up for about 500 meters in the driveway, and behind me and in front of me. Nobody could move. And I had to get out. I had about 10 minutes to get to the meeting venue. And I was stuck. So I looked at everybody sitting in the cars. The drivers resigned their fate, but I had to get to my meeting. So what I did is I got out, and I went to each car, knocked on the window, asked them to lower the car, and I said, "Come out. Come out." Each one. A lot of them came out, a lot of them hesitated, and there were some other people standing around. I asked them to come, and they didn't know what I wanted them to do. So they came and I said, "Let us take this car, lift this car, and put it on the sidewalk." They were taken aback a bit, and I said, "All we have to do is stand around." These four people underneath the car didn't actually happen, because AI is not very smart. So they were all standing around, and I was there too. We lifted the car up and put it on the sidewalk, and we all could start moving. So this is not a clinical scenario, but it's a scenario where a spontaneous, instantaneous team recruiting from total strangers achieved a seemingly impossible task of lifting a car and putting on the pavement. Now, what are the elements of instantaneous team motivation? There should be shared interest. we all wanted to get to our homes or wherever, and shared motivation. Someone had to motivate them all into, they have to recruit them into this and get them into shared action and then to achieve the shared goal. Now, I have told this story on this stage before, but for this particular talk, if you forgive me who have listened to this story before, let me repeat it again. The year was, I mean, these are a few of stories from my experience. I'm sure all of you sitting here, surgeons and physicians, all have their own stories of how they achieve team action in emergency, like Vishnu sitting there. They're always in the middle of it. And Philip, my friend, he's always in the middle of it. I'm sure you have lots of stories, but I'm just giving you my little stories so that we can think about our stories and how we can make our stories better. The year was 1980, and I was a 34-year-old young surgeon in a Middle Eastern country with only one cardiac center for the whole country. It's like a one-horse town, like you hear in the American Western stories. So there was a chief surgeon who was a local man. I was the second surgeon. And I had just joined the department that year. So the surgeons, I mean the senior surgeons, cardiac surgeons especially, are very jealous of their juniors. They don't allow them to work. They don't allow them to operate. So I was just assisting this man for about a year. And then he took a month's vacation. I don't know if it is deliberate. I suspect it was deliberate. He gave holidays for the perfusionist, one perfusionist, who runs a heart-lung machine. So I had no way of operating. Secondly, he ordered the operating theater air conditioning to be redone. So workers came, they pulled out the roof, the ceiling, everything. There were rubbish all over the operating room. And it was the middle of summer. And the middle of summer in Kuwait, as some of us know, is extremely hot. And you cannot stay indoors in the middle of summer. So I was resigned to not operating, having just running the outpatient and having an easy time during the whole month. And one afternoon, I was walking down the corridor. I saw this man pushing a wheelchair down the corridor with a woman slumped in it and coughing out blood, large quantities of blood. And I had my stethoscope with me. I approached the patient, apparently the patient, and I asked the man what happened. And he said that she started coughing out blood. She's not well. I asked him what is the history. He said she had a heart valve replacement a few years ago in London. And I took out my stethoscope and put the stethoscope to the chest. And I could hear a funny ringing sound, which was not like a normal valve. And suddenly, no sound. The ringing sound disappeared. And she collapsed, completely collapsed. So I pushed the wheelchair to the intensive care unit. I intubated her myself, put her on a ventilator. And then I had to make a diagnosis. There was no echocardiography, was not very developed in those days, cardiac ethics. This lady is not going anywhere from that bed. She cannot be moved. She's on a ventilator. So I had my colleague, my friend and classmate, Dr. Velayathan Pilla was my colleague. There were suddenly from nowhere an X-ray technician called Uman, he's also Malayali, he appeared. And we were discussing how to see if what happened to the valve. And Uman suggested spontaneously, I will bring the image intensifier, I'll bring the C-arm, and let us screen the patient. So he brought the C-arm, and we screened the patient. And this is what we found. This is the ring of the Bjork-Shiley valve, which I showed before. This is the valve. The valve has got a ring, and there is a disc inside held by a hinge. But in this, you could see only the ring, no disc inside, only half a hinge. So what happened to the valve? We went down to the abdomen, and it was in the abdominal aorta. The ring of the valve was in the abdominal aorta. So this is a lady without any valve at all, free mitral regurgitation, pulmonary edema, blood backing up into the lung, and she was pouring out blood from the endotracheal tube, and the nurses were continuously sucking blood out. And she needed an urgent operation. I have no operating room. I have no perfusionist. And I had no way of doing it. But I had to do it. So my friend Pillai immediately said, I will run the pump. He's an MCH from CNC Vellore, and he said, I have put together the pump there during my training. I can put together the pump. I'll try to run the pump. I had no choice. I said, okay, let us do it. But where to operate? The operating room is not working. So I ran to the operating theater and told the nurse in charge, again Malayali, Mary, I told Mary, how long will it take you to push out all these people, pull out all the debris and planks and things, and just at least dust the floor of the theater? And she said, I'll do it. So I ran to the blood bank and asked them to cross-match blood. And in the meantime, one Palestinian junior cardiologist came to me and said, John, my sister is a perfusion technology student in Glasgow, first-year student. She's here on holiday. Shall I call her? I said, do that immediately. So he calls his sister, who is a first-year student in the 4-year course of perfusion technology. And a little later, he comes and tells me, we have a family friend who is a perfusionist in Canada. He happens to be here on summer holidays. Shall I call him? So I said, call him. So he calls him, and I immediately get a call from this man. Says, Doctor, I'm not registered to work in this country. I said, to hell with, I didn't use that word, but just don't forget about it. Just come. And then he says, Doctor, I'm not a human perfusionist. I work in the animal lab. So I said, I'm sure you have put dogs on cardiopulmonary bypass. He said, yes. I said, okay, just consider this is a 70-kilo dog. Please come. So he comes, and I talked to so I got everything together, and I talked to the husband, and I said, she needs an urgent operation. Oh, this is the situation. If she can be transported to another country, which would be a neighboring country by flight, I will come with the patient, but I don't think she will make it to the airport. And he said, would you give consent for surgery? And he said, let me talk to the Minister of Health. I didn't know he was a friend of the Minister of Health. So he talks to the Minister of Health and comes back to me and said, the Minister said, if Dr. John says he will operate, let him operate. So you go ahead. I didn't know the Minister. He didn't know me. But, I got immediate administrative approval to go ahead from the highest authority. So we push the patient to this dirty operating room. Minnie is shaking her hand because she is the head of infection control. Dusty, no AC, hot, sweaty. We pushed her in, and the animal perfusionist came. This is a redo operation, you should think. Then it's not easy to open the sternum second time, mobilize the heart. And the wonderful thing is that God kept her alive all this time. She could have a cardiac arrest. During my opening, when I'm pulling on the heart, pushing on the heart kept going. Put her on bypass, and we did the surgery, took out this ring, and put a new valve in. And I didn't know whether the heart was going to beat or not, because I was sweating, the patient was sweating. We were supposed to cool the patient during open heart surgery, and he was trying his best. He could not cool the patient. She was sweating underneath. Only the anesthetist could go out in between. And I forgot to mention the anesthetist, Egyptian anesthetist. When I said we are going ahead, he did not hesitate. He should not say that, oh, this is a high-risk case. How can she? I don't think this patient will survive. I don't think you should operate. No. He joined the party. All of them joined the party. Because of the enthusiasm, everybody joined the party. And we completed the operation. To cut a long story short, she was pushed out to her own husband took her out of the hospital about 10 days later in a different condition than she came in. And what happened to this, the disc in the abdomen, at the end of the surgery, we debated whether we should open the abdomen and take it out, but we had enough, and she had enough, and she had femoral pulses. So we said, let us leave it there for the time being. We'll take it out a little later. So she was discharged well, and 6 months later, we got her back, opened her abdomen, and took out this disc. And the surgeon, the vascular surgeon who took it out, he did a free appendicectomy and cholecystectomy at the same time. So this shows that, I keep remembering this quote from Paulo Coelho. When you really want to do something, the whole universe conspires in helping you achieve it. This is a good illustration of things. When we were, bent on going forward, I didn't know where all the help came from. People were coming forward from unexpected quarters. An animal perfusionist from Canada, he was there, happened to be, and he came. So this illustrates that, when you really want to do something, don't hesitate. This story was published in this book, 28 Voices in Non-Fiction, and this is published in New York. And this is the co-author holding the book there in a book exhibition. Now, let me go to another scenario. I've been around for a long time. I'm the oldest member in this audience. So, my stories go way, way back. There was a time when cardiologists used to do cardiac catheterizations, and then we used to do closed valvotomies for mitral valve, and then they started doing balloon valvotomies. And in the early days of balloon valvotomies, I had 3 occasions where the cardiologist perforated the heart. So when you perforate the heart, as you can see here, this is a ventriculogram. You can see the dye extravasating outside into the pericardium. It causes pericardial tamponade, and the heart gets compressed, and it's a fatal condition if we don't intervene. So the patient is on the table. They usually try to put a catheter into the pericardium, try to aspirate it and push it into the femoral vein. And patient was nearly arrested. My first patient was nearly arresting when I reached there. So there was no time to shift the patient to the operating room. And there is no operating set in the cath lab. And there is no theater nurse. All you can do is call the anesthetist, call the theater team, and let them bring all this. And all you usually get in a cath lab is at best a blade without a handle, a surgical blade without a handle. And I must say, I have done this type of thoracotomy at least 7 times in my life. Here it has been done about 3 times. My colleague Kanan also did one. And all of them survived. I must say, all of them survived. The only way to do it is, see, this is again following a coronary angiography. There's a perforation of the coronary artery, and the dye is extravasating into the pericardium. The thing to do is, the best way to approach is, you cannot do a sternotomy with a blade. The best way to do is to open the intercostal space with the instrument you have, even if you only have a blade. And I have done it many times without washing my hand, without putting a sterile gown on, and I have done it twice without putting gloves on. And there is the question of infection. Will the patient live? Honestly, I have done it without putting gloves on 2 times in my life. This is the heart, and just open it. The best approach is to open the intercostal space. Ask someone to put their hand in, because you don't have a retractor to spread the ribs. Another person, anybody, to pull the ribs apart and open the pericardium and put your hand inside, and you can massage. You can put your thumb on the hole in the heart, the injury which has been produced, until help comes. The last time it happened here, I remember on the table, it was a coronary angiogram, I think, and the patient had arrested on the table. And I arrived first. I asked for a blade, and then I said, call Benson. Benson is not there. Call Benson, call Vishureha. They are my lifesavers. So that is all I have to do. And before they came, I opened the chest without anesthesia, because the patient is unconscious anyway. I opened the chest and I had put my finger on the bleed. And while I was doing, Benson came and intubated, and Vishwadeha was there with all the operating set. So once they came, I could put a couple of stitches on the heart, and then everything became calm, and I went out and scrubbed and gowned and came and completed the operation. So as I said, I have done it at least 7 times in my life. And when I was in this Gulf country, Kuwait, an English cardiologist was visiting, and he also had similar injuries with the balloon valvoplasty. They had a very stiff guide wire in those days. Now they have improved it. And he said he had 2 times perforation on the cath table, and both of them died because he could not get someone to come and open in time. So, it's very important that someone should be around, someone should take the responsibility to go ahead and take the risk and open the chest. Open the chest and relieve the tamponade. Now, this very unfortunate incident occurred a few months ago. One of our old colleagues had his father admitted to one of the neighboring hospitals, and they did a cardiac catheterization, and he had a cardiac perforation, and he was tamponaded, and he was arrested. They were doing a cardiac massage, and his son, who was our colleague, called me and said, "Sir, can you come over quickly? And I said, "I'll come over quickly, but before I come, someone has to be, is there a surgeon there? Is there a surgeon there? Is the surgeon there?" I said, "Yeah." He said, "Yes." He said, "Give the phone to the surgeon." So I got him on the phone. I said, "You have to immediately open his chest on the cath table, and you control the bleeding, relieve the tamponade, control the bleeding, put your finger on it, and I'm on my way. Just do that." So I put the phone down, and then I got into my car. It took me 10 minutes in the traffic to reach there, and parked the car, and I went into the cath lab, and I asked him, did he open? And he said, "No." So I said, asked the surgeon why he didn't open, and he said, "Infection, cath lab infection." And other thing was medico-legal. So if you think about infection, all the negative things, medico-legal, you won't save a life. I must say, all these 7 cases have opened without scrubbing, even without gloves. None of them had infection. I don't know how to explain it, but that is not the important thing when an emergency arises. You don't worry about these things. You just go ahead. Now, we had another case recently. This is a baby who swallowed a button battery. The button battery injury is fairly common these days because of this small watch button back. And this baby came with severe hematemesis, in a collapsed state. Hemoglobin was about 3 or 4, and they were resuscitating, and they gave blood, and then my friend, gastroenterologist, came and did an endoscopy and found that his button battery was stuck in the esophagus. So it was obvious that the child had an aortoesophageal fistula because of this battery, which had eroded chemically through the esophagus and also into the aorta. So we could see the battery sitting there, and I said, it's better not to take it out right now. But unfortunately, because of the movement and manipulation, it came out, and it came loose, and it was taken out. And there was no bleeding because there was a clot which was stopping the bleeding. There was no bleeding. And we said, okay, let us plan a thoracotomy and repair. And while we were planning and preparing blood and everything, the child bled again. Massive bleeding from the esophagus. Most of it is going down, so we don't see it collapsed. No pressure. And I was there, and my anesthetist, Dr. Sajith, was there. And there was no time for us to call for the trolley or shift to the theater or anything. We just made a phone call. Somebody called the theater and said, we are bringing this baby for thoracotomy, and Sajith carried the baby. Somebody else, our anesthesia technician, was bagging and carried and ran through the lift and went 2 floors down and onto the theater. And by that time, I ran in front and I got ready for thoracotomy. We did a thoracotomy, and this is what we found in the aorta. There was a communication between the aorta and the esophagus. And I was foolish in this case, I must say. I thought I could repair it directly. So I repaired it directly, and no bleeding, everything good, patient stable, transfused, reasonable hemoglobin. We sent the patient back to the ICU, to the pediatric ICU. And we thought everything was going to be fine. 2 days later, baby was extubated, I think, if I remember correct. 2 days later, the same thing occurred. Massive bleeding. So we were called into the ICU. Again, Sajid carried this baby. Honestly, he had no time else. So 4-year-old child, carried this baby to the operating room, and the same exercise was repeated. But this time, I realized that this chemical had eroded much more of the aorta and much more of the esophagus. So I had to do a resection of the aorta and anastomose it and repair the esophagus in a more extensive way and put some pericardium in between so that they don't. So that's what I should have done in the first time, but I didn't. So that's why. But second time also, because of this quick coordinated action, we were able to save the patient's life. This is not my own story only. I'm sure you all have such stories where you have done heroic things and people have aligned with you, helped you. I just want to, people ask, we are doing something else. We have an outpatient, we have 50 people to see. We send this patient to somebody else. He will do it. I cannot do, so I'm sending it to somebody else. Here, I'm hoping he will do it. Or I have other things to do. I haven't finished my rounds. I will hand it over to somebody else. But I just want to remind you of this parable. Luke 15:4 says, doesn't he leave the 99 in the open country and go after the lost one sheep and until he finds it and saves it? At this moment, nobody does it better than my brother Luke sitting there. Because when I saw this verse in Luke's gospel, I could not forget the namesake, Luke. He is a pain in the neck for the sake of his patients. So is his neighbor, S.K. Matthew. These are the people who don't give you any peace until you do what is required for their patients. So I think we should be pains in the neck for the sake of our patients and make sure that the right thing is done. Even if you are not doing it, you have to make sure that somebody else is doing it. And I'm operating on your patient today. Thank you. So in an emergency, a team doesn't wait to be formed. You'd be amazed, it forms itself. It forms itself. You just have to make us out. You have to make your intentions known, and it forms itself. And what we need is doctors who are alert beyond their specialty, and nurses who can adapt to any ward or situation, and technicians who can switch gears. We have an amazing group of technicians in our theater, and also administrators who can lead logistics on the go, which we have, thank God. So I just want to conclude with this. I have some more stories, but I don't think I have enough time to give you all those stories, and you can give your stories after I finish, I'm sure. And I just want to conclude with this. When you want to do something, the whole universe conspires in helping you achieve it. Thank you. Thank you. Oh, yes, madam.
അത് ഞാൻ പറയാൻ പോകുന്നത് ദൈവത്തിനെ പോലെ ഞങ്ങളുടെ ഫാമിലിയുടെ മുമ്പിൽ വന്ന് പെട്ട ഒരു വ്യക്തി, അല്ലെങ്കിൽ ദൈവം എന്ന് തന്നെ പറയാം. അതാരുമല്ല, ഡോക്ടർ ജോൺ വല്യത്ത്. എന്നാലും എൻ്റെ സിസ്റ്റർ, മൂന്നാമത്തെ സിസ്റ്റർ. ഞങ്ങൾ 5 പെൺകുട്ടികളാണ്. അപ്പോൾ പുള്ളിക്കാരിക്കൊരു മൈട്രൽ വാൽ ഇതുണ്ടായിരുന്നു. ഷീ വാസ് ലിവിങ് വിത്ത് ദാറ്റ് പ്രൊലാപ്സ് ഉണ്ടായിരുന്നു, മൈട്രൽ വാൽ പ്രൊലാപ്സ്. ഷീ ഈസ് ലിവിങ് വിത്ത് ഹാപ്പിലി. സഡൻലി ഡ്യൂറിങ് she is a teacher. One vacation സമയത്ത് she do some hard work and some infection had got into the body. അത് കഴിഞ്ഞ് നമുക്ക് എവിടെയാണെന്നൊന്നും അറിയാൻ പറ്റും. ഷീ ഈസ് ഹാവിങ് കണ്ടിന്യൂസ് ഫീവർ അപ്സ് ആൻഡ് ഗോയിങ് ഡൗൺ. അങ്ങനെ ഞങ്ങൾ സാധാരണ ട്രീറ്റ്മെൻറ്റ് കഴിഞ്ഞിട്ട് നമുക്കൊന്നും ചെയ്യാൻ പറ്റാഞ്ഞിട്ട് we will take her to the SUT hospital where my Dr. K.P. Polos are there because he was our HOD in general medicine. അദ്ദേഹത്തെ കണ്ടു, ട്രീറ്റ് ചെയ്തു. പേഷ്യൻ്റ് വാസ് 70 കാർഡിയാക് ഫെയിലിയർ. ഫീവേഴ്സ് നോട്ട് സബ്സൈഡിങ്. ദ ഡയഗ്നോസിസ് വളരെ ഇച്ചിരി ഡിലേ ചെയ്തു പോയി. പേഷ്യൻ്റ് ഞാനിവിടെ നിന്ന് കോട്ടയത്തു നിന്ന് അവിടെ എത്തുമ്പോൾ പേഷ്യൻ്റ് ഈസ് ഗ്യാസ്പിങ്. And she was put into the ventilator, and she was ventilated for 7 days. No improvement, fever not decreasing, continuous fever. Then echocardiography was done, and it was found to be infective endocarditis. The wall has been badly damaged, severe cardiac failure. No, ഒരു മരുന്നും വെക്കുന്നില്ല, എല്ലാ ആൻറ്റിബയോട്ടിക്സും കൊടുത്തു, കൾച്ചർ ചെയ്തു, നത്തിങ് ഈസ് ഹാപ്പനിങ്, ഫീവർ കണ്ടിന്യൂസ്. അപ്പോൾ ദൈവത്തിൻ്റെ ഒരു വരദാനം പോലെ അന്ന് ഭരചന്ദ്ര സാറുണ്ടായിരുന്നു. ഞങ്ങളെ വിളിച്ചു, എൻ്റെ ഒരു ഫ്രണ്ട് വരുന്നുണ്ട്, അപ്പോൾ ഇവിടെ അദ്ദേഹം ഇവിടെ നാട്ടിലുള്ള ആളല്ല, ഏതോ ലീവിന് ഇവിടെ വന്നിട്ടുണ്ട്, ഹി വിൽ ബി കമ്മിങ്. ഞാൻ അവൻ്റെ ഡിസ്കസ് ചെയ്യട്ടെ, നമുക്ക് സർജറി ചെയ്യാൻ പറ്റുമോ എന്നുള്ള കാര്യം. നോ ബഡി ഈസ് ഡെയർ ടു ടച്ച് ദാറ്റ് വാൾ ഇൻ ദാറ്റ് കണ്ടീഷൻ ഓഫ് ദാറ്റ് പേഷ്യൻറ്റ്. ശരിക്കും സത്യം പറഞ്ഞാൽ ദൈവം ഞങ്ങളുടെ മുമ്പിൽ ഇങ്ങനെ നടന്നു വരുന്നതൊക്കെ ഞാൻ കണ്ടു. ജോൺ വല്യത്ത് സാർ നടന്നു വരുന്നത് കണ്ടപ്പോൾ, അന്ന് ജോൺ വല്യത്ത് ആരാണെന്നോ സാറാണെന്നോ ഒന്നും ഞങ്ങൾക്കറിയില്ല. ദാറ്റ് ഈസ് വൺ ഓഫ് ദി ബെസ്റ്റ് ഫ്രണ്ട്സ് ഓഫ് ഭരചന്ദ്രൻ സാർ. സാറ് വന്നു വളരെ അൺഅസ്യൂമിങ് ആയിട്ട്, ഞാൻ ഈ സാറോ ശരിക്കും ആൽപ്പേ വളരെ സിമ്പിളായിട്ട് സാറിൻ്റെ സ്ഥിരം നടത്തേണ്ട ഒരു തല കുനിച്ച് പതുക്കെ ഒരു നടത്തിലിങ്ങനെ വരുന്നു, പേഷ്യൻറ്റിനെ കാണാൻ വരിക. ഒരു ഗമയം തോന്നിയില്ല. തൊറാസിക് സർജൻ ആണെന്നോ എന്നൊരു തോന്നുന്നു. നമുക്ക് തൊറാസിക് സർജൻ്റെ കൺസെപ്റ്റ് ഉണ്ടല്ലോ, ഇങ്ങനെ വലിയ ടിപ്പ് ടോപ്പിൽ ഇങ്ങനെ വരും, ഹാഷ് പിഷ് വരും, നമ്മളെയൊക്കെ കാണും, ഹായ് ഹായ് എന്നൊക്കെ പറയും. ഇത് വരുന്നു, പതുക്കെ നടന്ന് കയറുന്നു, പേഷ്യൻറ്റിനെ കാണുന്നു. സഡൻ ഹീ മെയ്ഡ് ദ ഡിസിഷൻ ടു ഓപ്പൺ ഇത്. സാർ ഇപ്പോൾ പറഞ്ഞ ആ എക്സാമ്പിൾ നമുക്ക് ചെയ്യാം. എങ്ങനെ സാറ് ടീം ഉണ്ടാക്കുന്നൊന്നും ഞങ്ങൾക്ക് അറിയില്ല. എനിവേ സാർ ഓപ്പൺ ചെയ്തു, വാൽവ് ചുരണ്ടി എടുത്തു എന്ന് ഞാൻ പറയുന്നത്. അത്ര വാൽവില്ലായിരുന്നു കംപ്ലീറ്റ്ലി. സാർ ഓർക്കുന്നുണ്ടോയെന്ന് എനിക്കറിയില്ല, സാർ ഇതുപോലെ ഇഷ്ടം പോലെ, പക്ഷേ ഞങ്ങൾക്ക് ഓരോ സ്റ്റെപ്പും ഞങ്ങളുടെ മനസ്സിലിങ്ങനെ തങ്ങി നിൽക്കുന്നത്. അപ്പോൾ ചുരണ്ടി എടുത്തു, അത് സ്ക്രാപ്പ് ചെയ്തെടുത്തു എന്ന് വേണം പറയാൻ. വാൽവില്ല, കംപ്ലീറ്റ്ലി ഗോൺ. ഒരു ആർട്ടിഫിഷ്യൽ വാൽവ് വെച്ചു. വിത്തിൻ 24 hours ഫീവർ സബ്സൈഡ്. നൗ ഷീ ഈസ് ഓക്കെ, ഷീ ഈസ് സ്റ്റിൽ ലിവിങ്. I think it is in 2005, I think. She is living with that valve alone and continuous follow-up with my classmate Dr. Rajalakshmi. She is doing well. Thank you. That is a God came in front of my family. That is John Valiath. Thank you, sir. Thank you, sir.
Not really, thank you. I was grateful for the opportunity to come at the time. And I was really surprised to see you here, and you reminded me of that story. And it was really brought tears to my eyes, that it was my privilege and my opportunity to be there at that time. And so, thank you.
Anyone else with a story?
ആക്ച്വലി ജോൺ വല്യ സാറ് മുണ്ടിയപ്പള്ളിയിൽ എൻ്റെ അങ്കിളിൻ്റെയൊക്കെ വൈഫിൻ്റെ അവരുടെ ഇതാണ്. അപ്പോൾ എൻ്റെ കസിൻ അവിടെ നിന്ന് വിളിച്ചു പറഞ്ഞു, ബാംഗ്ലൂർ അവരുടെ ഒരു കാർ ഡ്രൈവറുടെ മോള് ഒരു ഏട്രിയ ഇല്ലെന്നോ അങ്ങനെ എന്താണ്, അപ്പം അവിടെ ഒന്ന് വത്സമാമയെ ഒന്ന് അന്വേഷിക്കുമെന്ന് പറഞ്ഞു. സോ ഐ വെൻറ്റ്, പോയി. അപ്പം രാവിലെ ആയിരുന്നു, അപ്പോഴേ സാറ് ചെയ്യുക. 5:30 ആയിട്ടും തീരുന്നില്ല. കുറേ അത്രയും സമയം, ദ ടൈം ഹീ സ്പെൻഡ്സ് ഫോർ വൺ പേഴ്സൺസ് ലൈഫ്, അത് ഞാൻ അറിയുന്നു. എത്രയോ ഒരു ഞാൻ എപ്പോൾ ചെല്ലുമ്പോഴും ആ കൊച്ചൻ പറയും സാറാകത്ത് ചെയ്തുകൊണ്ടിരിക്കുക. ആൻഡ് ഇറ്റ് ടുക്ക് സച്ച് എ ലോങ് ടൈം. അപ്പം ഞാൻ ഓർത്തു, അത് കഴിഞ്ഞിട്ട് ഈ അടുത്തിടെ എനിക്ക് സാറിനെ ഒന്ന് വിളിക്കണമായിരുന്നു ഒരു കാര്യം. അപ്പം വിളിച്ചപ്പോഴേ ഒരു അസിസ്റ്റൻ്റ് എടുത്ത്, അത് കഴിഞ്ഞ് പിന്നെയും വിളിച്ചു, പിന്നെ രാത്രി ഞാൻ വിളിച്ചു. അപ്പോഴാണ് മനസ്സിലാക്കുന്നത് ഹീ ഫ്രം മോർണിംഗ് ടു എത്ര മണിയാണെന്ന് ഞാൻ ഓർക്കുന്നില്ല, 10 ഏത് പേഷ്യൻ്റാണെന്ന്, ഒരു കുഞ്ഞോ എന്തോ ആണ്. അപ്പോൾ ഹീസ് ഇൻ ദ. അപ്പം ഞാൻ സാറിന് വേണ്ടി പ്രാർത്ഥിക്കുന്നുണ്ട്. അപ്പം ഞാൻ പിന്നെ സാറിനോട് ചോദിച്ചു, എന്താ ഇത്രയും സമയം സാറിനെ അവിടെ ആരുമില്ലേ, അല്ലെങ്കിൽ ആ പേഷ്യൻ്റ് മരിച്ചു പോകുമെന്ന് റേഡിയോളജിയുടെ ഡിപ്പാർട്ട്മെൻറ്റിലാണ്. സുരേഷാണ് എൻ്റെ ഫാദറിനെയും രക്ഷിച്ചൊരു അന്ന് MD ചെയ്യുമായിരുന്നു, ട്രിവാൻഡ്രത്താണ് കാർഡിയോ. അപ്പോൾ പറഞ്ഞു ഇല്ലെങ്കിൽ ദാറ്റ് പേഷ്യൻ്റ് വില്ലോ. അപ്പം ഞാൻ സാറ് ഇവിടെ വന്നപ്പം ഞാൻ സാറിനോടൊരു ചെറിയ വഴക്ക് പറഞ്ഞു, സാറേ സാറ് കുറച്ച് റെസ്റ്റ് എടുക്കണം അല്ലെങ്കിൽ ഇതാ. അപ്പോൾ എന്നോട് സാറ് പറഞ്ഞൊരു സെൻറ്റൻസ് പറയാനാണ്. സാറ് പറഞ്ഞു, നീയോ ഞാൻ കുറയണം, വളരണം. അപ്പോൾ ദാറ്റ് കുഞ്ഞ് ഇപ്പം ഞാൻ മരിച്ചു പോയാലും കുഴപ്പമില്ല, ആ രീതിയിലാണ് ഹി സൈഡ്. കുഞ്ഞിൻ്റെ ജീവൻ രക്ഷിക്കാൻ വേറെ ആർക്കും പറ്റത്തില്ല. ദാറ്റ് ആക്ച്വലി ടച്ച്. ഞാൻ അത്രയൊന്നും ആയിട്ടില്ല. സോ ദാറ്റ് ഇൻസ്പയർഡ് മീ എ ലോട്ട്.
Thank you, sir. Sir, regarding that child with the button battery, that child might not have been alive if he was not here at that particular time. അത്രയും ഒരു ടീം, so many people work with sir. അപ്പോൾ പറഞ്ഞു എടുത്തു രണ്ടാമത്തെ bleeding was very massive. It was picked up by the sister who was there, which suddenly said child was fine. Immediately child became pulseless and child went to severe shock. Whatever resuscitation we could have done, it wouldn't have saved the child. If we did not have this team, if we did not have everybody, the team which is formed immediately and things were done in such a spontaneous manner, that child is alive purely because that child was here at that particular time. And thanks to sir for all the services which he has done.
I'm sure many of you will have stories to say, and I hope you will write it down so that we can make a book out of it. This was fantastic. This is only 1/10 of the presentations that Dr. John has to tell us. But I think the purpose for which he made this presentation is because we found that ഒരുപാട് നമ്മുടെ ഭാഗത്തുനിന്ന് ലാപ്സസ് വരുന്നുണ്ട്. Many patients are losing out because of our inactivity. അത് ചോദിച്ചപ്പോഴത്തേക്കും കാരണം പറയുന്നത് ഞങ്ങളുടെ റെസ്റ്റത്തെ ജോലി ചെയ്യണ്ടേ. So we have to find an answer for this. I'll request the medical superintendent to think through this. What do we tell ourselves? അപ്പോൾ സാറ് ഇപ്പം നമുക്ക് 3-4 സ്പെസിഫിക് എക്സാമ്പിൾസ് നമുക്ക് പറഞ്ഞു. അപ്പം when you see something, അതുകൊണ്ട് we've created something called ICRA, Immediate Complete Response Agreement. And we want all of you to sign this when we start our patient first movement tomorrow. And the patient first movement means a total commitment, Dr. John നമ്മളോട് പറഞ്ഞതുപോലെ. So can we now onwards say, anyone who has a need, ഇതെൻ്റെ അല്ല വേറെ ആരുടെയോ പേഷ്യൻ്റാണ് എന്ന് വിചാരിക്കാതെ, we jump into it and see whatever we can do. Try to get in the people, and that's one of the messages Dr. John gave us. And that's his final Paul Coelho quote, that when we do that, the world will conspire together to help us. അതൊരു ഡിസിഷനായിട്ട് ഇപ്പോൾ പേഷ്യൻ്റ് ഫസ്റ്റ് മൂവ്മെൻറ്റിൽ ത്രൂ ഔട്ട് ദ ഇയർ പ്രാക്ടീസ് ചെയ്താൽ. ആൻഡ് ദ അതർ സ്റ്റോറി ദറ്റ് ഹി said about where he called another hospital, they didn't listen to him and the patient died. Somebody very close to us, where hospital poi. On the other hand, yesterday we read the story about Dr. Tina going to another hospital and stopping a post tonsillectomy bleeding. So I'll request all of you, if you have example stories, Ramla ma'am parnaduvole, let's put it in the public domain so that we get encouraged to do this. And tomorrow please come for the morning service at 8 o'clock and the public meeting at 3:30, because unlike other meetings, we don't want it to be just another meeting. We want to create a culture change amongst us, because if we really feel for the patient, that's what Dr. John demonstrated in all these cases. He thought of those children as his own, or the patients as his own, and responded, what would I do for my son or my child? അങ്ങനെ നമുക്ക് ചെയ്യാൻ ഒത്തെങ്കിലേ we can bring hope and healing, and I hope we can do that. Shall we all just rise as one to applaud this wonderful man?
Thank you, sir. And we'll convene again tomorrow for the patient first movement. And thank you.